Hello, everyone. Thank you for joining us. My name is Nathalie Toublanc. I'm a scientist at Simulation Plus, but I'm here today as a Gastrophysiology Group Committee member. It's a great pleasure for me to introduce the speaker and the moderator of today's webinar. And in this webinar, Xavier Pepin will discuss the P-PSD approach for translation of in vitro to in vivo dissolution. So before we get going, I want to give a few housekeeping items. So we take your privacy rights seriously. By attending this event or participating in the Q&A session, you are allowing us to contact you for follow-up. And you may ask the question via the questions panel on your dashboard at any time. And if you need assistance, please use the hand raise icon and we'll address all the questions in the Q&A after the presentation if we did not manage to cover all of them during the presentation. So that was really the housekeeping. So please make sure that you have the questions through the Q&A. So our speaker today is Xavier Pepin. Xavier is the pharmacist from the where he studied at University of Paris 11. He has a PhD in granulation technology. He has more than 25 years experience in the pharmaceutical industry and has worked in biopharmaceutics for 15 years using in vitro, in silico, and in vivo tools. He is the author or co-author of more than 50 publications and has given presentations in various conferences and webinars. And he is at the origin of the P-PSD concept. And people who are working in the biopharmaceutics field have likely heard of him. And Xavier joined Simulation Plus in the regulatory department 1.5 years ago. Our moderator today is Sivacharan Kollipara, who is the chair of the Gastrophysiology Group Committee. Sivacharan has an experience of 16 years in the pharmaceutical industry and is currently working as a biopharmaceutics lead at Dr. Reddy's Laboratories Limited. There he is responsible for biopharmaceutics evaluation, bioequivalent risk assessment, and prediction for conventional as well as complex generic products. He has authored or co-authored 25 publications and presented in different conferences. So we are in very good hands today. So without further ado, let's get going. Xavier, the floor is yours.
Thank you, Nathalie, for the kind introduction. So today we will be talking about P-PSD, and I'll introduce it through the dissolution equations, and then we'll look at the different parameters that can influence dissolution and how it's really important to consider these when you want to do dissolution modeling. We'll then move to the actual modeling of the dissolution, how to choose the right method, what are the assumptions, what are the different tools and limitations. And finally, I'll show you how the different methods compare in terms of their in vitro prediction performance, but also in vivo prediction performance. We'll finish with some, let's say, case studies which are not necessarily always seen or always you're not always familiar with. Is what to do when you see sedimentation, and a final decision tree. I'll finish with a decision tree on choice of dissolution model and some take-home messages. So let's move to the basic concepts. I think you're all familiar with this Noyce-Whitney equation, which relates the mass dissolution to the surface area of the drug, diffusion coefficient, thickness of the unstirred water layer, drug solubility, and bulk concentration. So the assumption here is that there is an unstirred water layer surrounding a particle of solid which has a certain thickness, and the drug diffuses from the equilibrium solubility at the surface of the solid towards the bulk, so you start with zero concentration in the bulk at time zero, and then concentration increases. Once you reach the solubility, the dissolution stops. So you're all familiar with that, and all the equations that handle dissolution with the unstirred water layer concept are derived from that Noyce-Whitney equation. So the first parameter, which is really key, and that's actually the heart of the presentation today with the P-PSD, is that A versus time, the surface area of drug substance available the dissolution. So in our case, because we give product to patients, we are mostly interested in the drug substance available within a drug product, and that can be quite different from the one that you assess from, let's say, a diffraction laser scattering. So if you have a sizing method, whatever it is, it could be something else than DLS, but if you have a sizing method for your drug substance, you will not necessarily measure the right surface area, or at least you will measure a different surface area than the one present in your product. Why? It's because you have to consider lots of the process manufacturing conditions, lots of the excipient effects, which can change that surface area. But let's first start with the sizing method. So when you do DLS on a dispersion of powder, whether it is a dispersion in liquid or in a dry method, so in air, you are projecting a laser and then you're diffracting it around the particles. So you are actually assuming that all your particles are spherical. So you're looking at the volume equivalent to a sphere, or the spherical equivalent to the volume. And if you have a shape which deviates largely from the spherical morphology, you're making a big mistake, because depending on how the particle is oriented towards the laser, you could see it large or small. So that's one first problem. The second one is the aggregation. If you have primary particles which have their own surface area, if they are aggregated, the laser will see one big particle, will not make the difference with primary particles. And of course, the method itself will be variable, because those aggregates can be loose or they can be hard. So they could, for example, disintegrate if you have a wet method, or if you have too much pressure with a dry method, they could also disintegrate. So you may have variability in your sizing method with the drug substance. So that's for the drug substance characterization. But of course, when you blend your drug with excipient, when you compress it, or when you granulate it, you're going to change that surface area. You could break the particles, and that will be preferentially starting with the larger ones or the aggregates. And that size reduction is not going to be anticipated from analyzing the drug substance. It's happening during the process manufacturing. So that's something you can hardly anticipate. You can measure it. I think there are some techniques like micro-CT or Raman spectroscopy. You can look at the surface of your tablet. You can try to look a bit deeper with CT methods. So you could try to characterize the surface area. But again, after disintegration, you don't know if particle has broken. That surface area may actually manifest itself after disintegration and not on the tablet. So the only method that we're going to use going forward is the drug product dissolution, because that's the one that represents all the contribution from all these processes. So I'll move on, but you can see the impact of the different parameters that can play on the surface area. So it's not really easy to characterize, and the P-PSD is actually starting from the drug product dissolution to fit the API surface area available in the product. The next parameter which is important is the diffusion coefficient of the drug, and that one is usually easily determined with looking at the true density of the drug, assuming that the crystal packing is representative of the packing of the drug in water, and that's relatively accurate for let's say crystalline small molecule. If you have a peptide, that's not going to work. If you have very small ion, because they can hydrate, that's not going to work. So there are some limitations there. And of course, one thing to consider, which is really important, is whether your drug is alone in the solution or is bound to cyclodextrin or to biosalts, for example, biosalt micelles. And you can see the size difference here, and I have a slide there on more size differences. Depending on the type of micelle that you're using in your medium or in vivo, the size can vary by several orders, one order of magnitude. And basically, if you imagine an unbound drug of about 1 nanometer diameter, it would diffuse 50 times faster when it is bound to FASF or 4 times faster than if it was bound to SDS respectively. So you can see the issue that you have with the diffusion coefficient if you do not take into consideration the size of the micelle, and also sometimes the pH can influence, especially if you have ionic surfactant. Sometimes most of the times the temperature influences the size, but the drug loading may also influence the size, because the drug may either bound to the surface, do mixed micelles, so interspace with the surfactant, or get deeper in the surfactant, especially if you've added lecithin, for example. You're adding a lipidic environment where the drug can partition. So it's usually recommended to measure the size of the free and the loaded micelle, so at the equilibrium solubility. The next parameter is the thickness of the unstirred water layer, which is H here in that equation, and Noyce-Whitney equation. And this depends on the hydrodynamics in the medium. So the assumption that we have in GastroPlus and in most softwares is that the size of the unstirred water layer, the H thickness, is equal to the particle radius up to 30 micron and then constant. And why did we come to that assumption? When you compute the thickness of the unstirred water layer as a function of RPM in USP2 or even in USP4, you can see that this, for very low agitation, this assumption is verified. And for very small particles, the size doesn't really change. It's only changing for very big particles. So that 30 micron is basically going to be a sweet spot where the agitation is close to the physiology. But this is something you can change in GastroPlus especially if you're targeting different administration routes, like the subcutaneous, for example, or intramuscular. The agitation, of course, in those administration routes is going to be much less than in the stomach. So you may want to allow for a larger threshold for the maximum diffusion layer thickness to allow for slower dissolution in vivo. But for the oral route, this assumption is fairly well respected, and you can trust it. There's very low agitation in the GI tract. Looking at impact of agitation is really important when you have large particles, as I've shown before, and that's an example here with felodipine. This is a measurement in USP2, 10 milligram in a medium mimicking the canine chyme, stomach intestinal environment, and you have here the dissolution at various agitation rate in USP2 for coarse suspension and a small fine suspension. And you see the impact of agitation is much more on the coarse suspension than the fine suspension. Solubility, the CS in the Noyce-Whitney equation, this is really key as well, and you have to look, especially if you have an ionizable drug, an acid or a base, you have to look at the reaction happening at the surface of your crystal. This is a concept that was introduced a long time ago by Higuchi back in the 50s, and if you have an acid-base reaction happening on the surface, you are consuming protons or you're generating protons, and that may change the pH at the surface and therefore the solubility at the surface of your drug. And that's the one driving dissolution, as was demonstrated since 1950s by multiple authors. So just to elaborate on that, if you have, for example, here a weak acid, you can see that the pH in the bulk can be as high as 14 if you have a dissolution of salicylic acid in 1 molar sodium hydroxide. So you're pH 14 in the bulk. And at the surface, you're only pH 4.5. So it's a massive difference. It's a massive error that you would make if you would only consider the bulk pH for handling your solubility for dissolution modeling. You need to consider surface pH because of that surface reaction. And this is true for weak acid, it's true for salts of weak acids, and it's true for weak bases as well. The thing you have to consider as well is the impact of excipients on the surface solubility. This is a very nice paper, a very nice example. You have the references here if you want to look further into this this example here. So here, this drug razaxaban, sorry, is an HCl salt of the free base, and I have fitted for you the solubility pH profile that was reported in this paper, and you can see that the salt has almost constant solubility until the pH max. There's a little bit of supersaturation as well, and then it crashes to the free base around pH 3, and then this is the expected Henderson-Hasselbalch equation. It looks funny here because I've only simulated the measured points, but it actually looks like a true Henderson-Hasselbalch equation. Interestingly, that salt crashes at higher pH, and you can see here at pH 5.5 with the formulation 1 that they generated, which just only comprised the salt and standard excipients, and nothing that could change the local pH apart from max T rate, but it's really low concentration. So if you're looking at this formulation 1, interestingly, if you dissolve, of course, if you dissolve it at pH 2, the salt is stable thermodynamically, so the solubility is high, more than 1 mg per ml. And here you have, I think it is 13 milligram. I need to check, but this is the salt mass. Oh, sorry, it's the percentage. No, it's the mass total weight. So you've got, let's say, 30 milligram free base. So if you dissolve it at pH 2, you've got almost 100% dissolution, and this is fine. And this is obtained at 60 RPM. Now, if you dissolve at pH 5.5, this formulation 1, if you dissolve it at 60 RPM, you can see an initial dissolution and then there's a plateau. If you increase the speed, the agitation, you dissolve a bit more, 70%, and then there's a plateau. And if you turn really fast at 100 RPM, you go all the way to the almost full dissolution. So the same formulation, the only thing you've changed is the agitation. So what's happening here? Clearly, we supersaturate with the salt. We are at pH 5, so the salt is following this orange line solubility here. So at pH 5, you still have a high solubility, so you can still kick in quite fast, but you have a mixture between dissolution and precipitation. So if you do not get rid of the API from the unstirred water layer fast enough, you can have surface precipitation on the tablet, and that will isolate the drug product. So all the drug salt which is present in the tablet will have a small layer of free base surrounding the tablet, and the dissolution will simply stop because the solubility of the free base at pH 5 is much lower at pH 5.5, so there won't be any more dissolution. But if you go really fast, you can kick in. So that's the parachute, right? It acts like a supersaturating drug. Basically, the solubility is high. It will kick in the drug in solution, and if you do not precipitate in the bulk, which is the case here at that dose in that volume, you basically can supersaturate and stay in solution for a long period of time, enough to be absorbed. But if you go too slow, you have surface precipitation on the tablet, and that isolates the dissolution. When you add excipients, the formulation 2, 3, and 4 are adding 16 milligram of tartaric acid in extragranular, intragranular, or citric acid extragranular. So you can see that the addition of acid at 60 RPM is actually helping that formulation, initial formulation 1, to dissolve fully, and even without further agitation, you can kick in more drug in solution, so you can maintain the microenvironmental pH, which is enough acidic to reduce that supersaturation and prevent that surface precipitation on the tablet. So do not forget excipients when you consider surface pH for your dissolution. The final element in the noise-Whitney equation, the concentration versus time, is another important thing to consider, because if you have a mixture of polymorphs in your dissolution, you can actually overcome the solubility of the first polymorph with a lower solubility polymorph. Here I've assumed that the polymorph 2 is the lowest soluble. So if the polymorph 1 is the highest soluble, it will continue to dissolve, and you may have a bulk concentration which now becomes above the solubility of the lower solubility polymorph 2. And in this case, the sign of this equation is well made, because it becomes negative, and two negative signs become positive. So you're actually growing mass. You will go from an initial reduction of mass, a dissolution, and then you will start to grow the mass, because you're precipitating your drug onto the polymorph 2. So mixtures of polymorph have a funny behavior, because they create plateau in dissolution. So you don't reach 100% dissolution, because you have that combination of dissolution and precipitation. Similarly, if you have degradation, you could have bell shapes in your dissolution, or a plateau before 100% dissolution, which may hide the balance between dissolution and degradation. And that's something you need to analyze as well, to understand if you see not 100% dissolution in your dissolution data prior to modeling. So let's move to the actual modeling of dissolution. First of all, you have to pick the right method. So we want to have a method which has the right level of discrimination. So ideally, if you have a choice of in vitro methods, you want to avoid under discrimination. So a method which is too rapid, here on the right, which may hide the in vivo relevance or have no in vivo relevance. You want to choose the right level of discrimination, so a change which is proportional in vitro to in vivo, the right rank ordering. You may still have a rank ordering with methods that are over discriminative, so having big changes in vitro but not necessarily a big change in vivo. So these two methods are usable, I would say, for modeling purposes. But the way to choose them is really to follow the 1x method. So to be in using dissolution conditions which are close to having the solubility of the drug in the medium, which is equal to the dose that you dissolve divided by the volume in the vessel. This concept was introduced by Jesse Cooper from Merck, and you've got the reference here if you're more interested. But basically, an easy trick to do is to draw a line between 0 dissolved at time 0 and the end of your dissolution measurement to 100%. So if you draw that line, and if you have the maximum number of points closer to this line, that's the right method. So here, for example, at pH 4.5 for that particular drug product, all the points are above 80% dissolution, so you're lacking discrimination. You don't want to use that method, the solubility is too high. At pH 6.8, all the points are below 20% dissolved, so you don't want to use that method, because you again have no discrimination for the inverse reason. You've got not enough solubility in the medium. And at pH 2, you only have 1 point below 80% dissolution, and all the others are above. So here again, you are lacking, you don't have any profile definition. So the right method in this case would be pH 1.3, where all the points that you have measured, you don't have many, you have only 4 points measured, but the 4 points are between 20 and 80%, all of them. So this will give you the best discrimination you can get. Ideally, you would want more points initially to look at the initial phase of dissolution, but it's not too bad. Actually, this is a real case study that was, I fitted this data with a P-PSD approach, and I predicted pH 4.5, 6.8, and pH 2. So these are predictions, and this is the fit. So that leads me to what kind of methods can we use to model dissolution, and how they compare, what are the assumptions we make. So the less mechanistic way to integrate dissolution in GastroPlus is to do a direct input or a viable fit. In this case, you just fit your data or use the data versus time. It's not mechanistic, of course, and in vivo you will release as a function of transit, so the time will be followed. Of course, you will release in different GI compartments in the ACAT model, and that may still lead to precipitation, to different metabolism, first pass gut extraction, absorption, etc., because the surface area in the gut will be different. So this post-release and post-dissolution processes will still be there, but the dissolution itself will be just function of time. So the assumption you make in this case is that your in vitro method is biopredictive, and basically that's the assumption you make to summarize it. So nothing is limiting dissolution, the hydrodynamics are perfectly representative, and sometimes it works. For most cases, you know, if you have a BCS class 1 or 1-like MR formulation or an eroding formulation, that can work very well. So I'm not saying you should never use VivoFit, but you know, you have to be conscious of the limitations. Moving down, you can use the Z factor or the P-PSD approach, and these are more mechanistic. The only difference between the Z factor and the P-PSD is the granularity. The Z factor is only 1 bin, and I will exemplify that. Whereas the P-PSD, you have a choice between 1 to 10 bins, or even higher, depending on the tool that you use. And this, they're both representing a size, and I will explain you this. So both these methods are mechanistic because they will depend on the pH, they will depend on the volume, they will depend on the dose and biosalt concentration that you have in your model to recalculate the local conditions for dissolution. When you look at the literature for IR products, there is a variety at the moment of methods that have been used. But if you only focus on low solubility drugs, you see the majority of the methods are using mechanistic models like the Z factor or the P-PSD. I'm going to skip that one. This is the Weibull equation. You have it in GastroPlus in the help. It's I would just want to say that you can be very flexible. We have in from version 9.7, we have up to 3-phase Weibull in Gastro, so you can actually fit lag times, multiple phases of release. That can be really handy for MR formulation, or when you do IV-IVC, when you do deconvolution of the oral observed PK. The Takano factor, the Z factor, was introduced in 2006. And if you see the equation here, this is a lumped factor. So you have the ratio of diffusion coefficient, true density, thickness of the unstirred water layer, and radius of the initial particles. And there's only one radius, and it's constant, so it's not changing with time. So Z is a hidden radius because you can manipulate that expression to express the radius as a function of Z, and I will give you an example later on. But as you can see here, sometimes it fits nicely the initial phase of dissolution, but if you have something which starts like a first order and then deviates from a first order, you may do a good job initially, and then you don't model well the remainder of the dissolution. So that could be an issue. There are some adaptations that have been published to the Z factor to account for example, sedimentation or disintegration, and these have been published. If you're interested, you can ask me the question in Q&A, and I'll send you the reference. The P-PSD that I will present today is a new equation which is derived again from the Noyce-Whitney equation. It can be fitted with different tools. There is you can do it in DDD+, and that's the example I'm going to demonstrate to you, but you can do it in Excel as well. You can download the Excel tool, and if you're interested as well, we can put the link of that tool at the end of the presentation. So you can the process to fit P-PSD is to pick one dissolution method to fit the data, and as I've just presented, you have to pick the most discriminative method. The second step is to verify in vitro that your P-PSD is predictive of other dissolution conditions, and the third step is the integration in the model. The second model, which was based on the P-PSD, integrates the hydrodynamics, so I'm calling it P-PSD HD, so you can manipulate the thickness of the unstirred water layer based on these equations, and you've got the reference here if you're interested, and that can help you fit the impact, for example, of viscosity on your in vitro dissolution. And finally, the third model is the P-PSD HDC, so it's involving the hydrodynamics and the coning as well, so you can utilize the information around the excipients amount, the swelling, the size, and you can fit the data and understand the impact of changing hydrodynamics in your USP2 on the sedimentation. And I will give you an example at the end. I'm going to skip that one. As I said, this is the Noyce-Whitney equation, and if you look quickly through this, you can always find an H. You can always find a radius or a size, surface area. You can always find solubility and bulk concentration. So they're all derived from the Noyce-Whitney equation. It's all building upon the Noyce-Whitney equation. The P-PSD Excel equation assumes a different diffusion thickness for the micelle and the free drug, and that's the novelty, I would say, compared to the previous models. So how do we enter the how do we fit the P-PSD? And I'm just going to give you an example on acalabrutinib, which is a free base, I would say, a diprotic base in the physiological pH range, but it also has an acidic moiety at 12.1, and we're never there in vivo. But that's the pH solubility profile for the free base fitted against the pH. You've got the measured value here, and this is the dissolution method I've picked. So I've picked the pH 6.8 data. I could have used a different one because I've just told you that we needed to maximize the number of dissolution points between 20 and 80%. And here I have 1, 2, 3, 4, 5, 6, 7. It's not too bad. We've got quite a lot to work with. And so I'm using that data which was measured on this capsule, L0505009 at pH 6.8. So when you do this, in DDD+, you can specify, so you enter your dissolution, that was what I've just shown you here. You enter your pH solubility profile. Then you enter your medium composition. So this is USP phosphate, 50 millimolar. Nothing fancy here. The dissolution was run at 75 RPM, and so that's pretty straightforward. And then you can optimize the P-PSD. So the thing you do is you in the formulation tab, you need to select your dissolution model. And here I'm going to use the same dissolution model as I will use in GastroPlus. So here is the Johnson spherical model. And you have the P-PSD here. So here in GastroPlus, in DDD+ and in GastroPlus, you can handle it with mean radius and standard deviation and number of bins. So here I'm fitting the P-PSD of that particular capsule batch at pH 6.8. by clicking on file optimization, module optimization. I'm selecting the objective function, which is to match the observed dissolution data to the calibrate mean radius and standard deviation. So that's by ticking these two options and running the optimization, I'm basically fitting the P-PSD to that data. You've got the results here, so you have the measured dissolution, the fitted data. It's really nice. It matches perfectly well the dissolution. So that's my first step. The second step that I've shown you was to verify. So this is really important. You need to verify that your model can predict dissolution in other conditions. So here I'm ticking in the dissolution model, I'm ticking this box here, which is to use the microclimate pH. So in DDD+, because I have a weak base, the software will calculate the microclimate pH, the surface pH, which will then drive the surface solubility for dissolution prediction. So you have here the prediction of dissolution pH 1. I remind you that we are talking capsules, so that point here at 90% is basically the opening of the capsule. And there's actually lots of variability associated to that measured dissolution. But if you see the dissolution is here well predicted, the pH in the bulk is 1, of course, but the pH at the surface is 3, and that actually corresponds to the measurements that we've conducted in vitro. So the DDD+ is using that surface pH to predict dissolution at pH 1, and at pH 3, it's using the surface pH of 5 to predict the dissolution at pH 3. You have here the prediction is nicely corresponding to the measurements. I went on to add some FASIF and FESIF. So these are measured values. You have the literature reference I gave, I think, at the beginning. You can check it's exactly the measured values in FASIF and FESIF. You can fit it. Or you can use the theoretical solubilization ratio. Here there was a bit of difference, but it's not major. But when you look at the prediction in FASIF, the bulk and the surface pH are equal because, of course, we have a phosphate here, which is let's say, forcing the solubility at the same, the pH at the same value for the bulk and the surface. And there's a nice prediction in FASIF, and fortunately we had another condition which was a modified FASIF with 4 times the biosalt concentration, and here again we've got a good prediction of the dissolution in that medium. So these 4 conditions constitute the model validation, so we can conclude that the P-PSD obtained with VDD plus on that batch is correctly predicted the impact of both the pH and the biosalt, which was the two factors which control the dissolution of acalabrutinib. So we're happy with that. So how does these method compare? And here I'm going to show you all the way to the prediction of the PK. So we've got different methods. The first thing I'd like to do is to show you the main difference between the P-PSD or the P-PSD that you do with XL or with DDD plus and the Z factor. So if I'm using the Z factor to fit the pH 6.8 data for that same capsule batch, I'm having the same prediction performance. Of course, that's a fit, so it's not a big feat. But if you look at the prediction in FASIF and modified FASIF, you're using with the Z factor, you have to use if you're using the FASIF apparent solubility, you're actually overshooting dramatically the amount dissolved, and that's because you do not differentiate the drug which is bound to micelle and the drug which is not bound to micelle. You would have to change the D in the Z factor. If you remember, the Z factor comprises the diffusion coefficient, so you would have to have an effective diffusion coefficient in the description of the Z. So the Z in reality should change if you're moving from buffers to micelle comprising media, because the diffusion when the drug is bound to micelle is less important, and so that would impact the dissolution rate, which you don't have here. So because of the construction of the Z with a fixed diffusion coefficient, this is not amenable to predicting with and without micelles, and I would really urge you to be very cautious about that. And of course, you can verify that it works in vivo, but it may have a strong effect. So in this comparison, I'm just gonna take 2 batches. So you've already seen the L05050009, which was the commercial formulation, and it was tested in a healthy volunteer study 112, with and without omeprazole. And I'm also going to introduce another batch, which was a phase 1 formulation, which was a simple blended capsule. And that one is interesting because it dissolves really differently from the previous one. It has a biphasic type of release, and there's an issue of workability with the API, which is just blended and put in the capsule. So you've seen DDD+. I'm introducing the P-PSD in XL, I'm introducing the Z factor, and I'm introducing the drug substance measured laser diffraction data. So here you see over just pH 1, pH 3, pH 6.8, roughly same prediction performance. There's not much to say apart from the DS particle size distribution by laser. We have a tendency to underpredict the measured dissolution, and that's because there's aggregation in that batch, and also the particles are not spherical, so it doesn't help. But if you look at the prediction performance, so absolute average fold error and absolute average fold error, ballpark prediction are really comparable with these 3 methods, and the laser direct introduction for the prediction, there's that under prediction with a bias with a 20% under prediction at both pH 6.8 and pH 3. So what happens when you compare the sizes? So I told you that I could re-express the Z, so this is the Z factor on that particular batch. But if you manipulate that equation, you can actually calculate a size. So a Z is actually a size, 1 radius of around 16 micron in this case of that product. So that's an easy way, if you want to basically compare things, it's an easy way to talk an equivalent Z factor radius, because you can then plot it. So that's the line you have here, 16 micron. This is the DDD plus P-PSD for that batch in orange. In red, you have the XL P-PSD, and in black, you have the laser diffraction. You see these aggregates here. in the laser diffraction, they're not in the product, they're not in the final product because that product is dry granulated. So you've basically destroyed those aggregates during manufacture. And that's the issue of using the drug substance as an input because you don't know what the process has done. When you put everything into GastroPlus, we had a model for that freebase, which was published in the literature. So these are the predictions. In that study, 112, you had 3 periods in the fasted state, 3 periods with the omeprazole. In blue, you have the clinical data. In red, the GastroPlus prediction with the XL P-PSD. In orange, with the DDD plus P-PSD. In green, the Z factor. And in black, you have the drug substance as an input. Overall, good prediction, I would say, for fasted state and omeprazole. Here you've got the AUC on the top, the Cmax at the bottom. There's no much difference. It actually seems that the drug substance gives the lowest errors, at least for the AUC. You see, even for the Cmax. Cmax is slightly worse, but AUC is really good. So you could say, drug substance didn't do a bad job in this case. Now, if we move to the second batch, I told you this was biphasic. So in the P-PSD in XL, you have multiple beams. So you can play on an initial fast release and then a much slower release, whereas in the Z factor, there's only one bin. So you can pass through one point and then you're missing the rest. In DDD+, there's only one mode. So you have an average radius and a spread. So you have the same issue here. You pass through the first point, but you miss the rest of the dissolution, and the drug substance was overshooting throughout. So a very bad prediction here. So just looking at this batch here, there was only one dissolution, so it was a very early batch, only pH 1 data. So it's really hard to compare across different pH. But from the AFE, you can see, that only the P-PSD XL was able to fit that data. Now, when you compare the sizes, you see that we have some for the P-PSD in XL, we have a spread, but we also have multimodal. We have some fines, and then we have very big particles. And the very big particles correspond to the slower dissolving phase of that batch. And it's basically a testing for a wettability issue. So it's putting mass within a very big particle. So the surface to volume ratio would be really low, and that would correspond to a slowly dissolving mass of drug, and that's what it does basically. The other approaches, so the measured particle size was centered around 100 micron radius. The Z factor picked only the slow diffusion, so the first point, but missed the initial phase of fast diffusion. So there's nothing here dissolved and nothing here dissolved. So as we had in the DS-PSD. So we know we have fines, we know we have some fast dissolving particles, but then there's issue with the second phase, which is slow. So, but the initial phase is fast, we know that, and it's completely missed with the Z factor because it's trying to fit that one point that was measured at 10 minutes. There was nothing measured here. So ideally, if we had some measurements before 10 minutes, it would have helped. But the only first point we have is at 10 minutes. So it's catching that point, but with a slow dissolution. And that's why the sizes that you get with the Z factor and the DDD plus P-PSD are quite high. They're around 500 micron, 700 micron. So what happens now when you plug this into GastroPlus and try to predict that batch PK? If you're looking at the fasted state, here again, in the fasted state, the AUC is well predicted. The drug substance is overshooting, which is interesting because it's also overshooting the dissolution. It was really fast all the way. And that's because the laser doesn't look at wettability. So if you're just looking at the laser diffraction, you see small particles, they dissolve fast, but in fact, no, they don't dissolve so fast. And you have to account for the wettability issue of the second release phase. That's not accounted by the laser. So it's doing bad for the AUC and the Cmax. And conversely, when you're looking at the omeprazole treatment, the one mode dissolution was also not accounting for the AUC with the omeprazole, and the Cmax as well is really under-predicted because the solubility in this case is much lower, but there was still a portion of that drug product which was dissolving fast, so that API which was available has been completely missed by the fitting because it caught only the first point at 10 minutes. So in this case, you can see that the prediction errors with the drug substance as an input are really large. Only the XL P-PSD fared well, and the Z factor and DDD plus didn't do so well. So when we explore the reasons why, again using the XL P-PSD, you can degrade the prediction. So that was the 7 bins 2 modes prediction. But if you only take 1 bin, you basically putting the XL P-PSD, you're using it as a Z factor. And when you look at the size, 516 micron is actually very close to the 520 micron we had from the Z factor. And if you express the Z factor as an equivalent radius, is worth 520 micron. So it's fairly the same, 516, 520. And we're catching that point as well. We're missing the initial rapid dissolution, and we are missing the rest of the dissolution. So and we have the same poor performance of the prediction. So 1 bin is not enough for a bimodal release, but if you take 2 bins or 2 modes, here with a 20 micron and a very large size, you can see that you're catching the initial phase. Of course, you lack a lot of discrimination here because it could be 20 micron, it could be 10 micron, 50 micron, doesn't matter, it's fast. And then you have that second phase, which is caught by that 30% drug load, drug mass into that large bin, which basically fits very nicely that second phase. So now what happens if I put this in GastroPlus? So as you would expect, the prediction with the 1 bin is poor. So both in terms of AUC and Cmax, we have under prediction. But if you have 2 bins, you're actually doing a good prediction of the AUC and a good prediction of the Cmax. So the minimum number of bins to fit a bimodal release product is 2. That's the conclusion from that analysis. Of course, you can add more if you want more granularity, but the minimum number you need is 2. And this is why it's important to have multimodal tools or P-PSDs if you want to have more complex, if you're looking at more complex phenomena. Right. I'll move on to looking at sedimentation, and because that can be an issue for some formulation, I just want to illustrate it with one example. So the sedimentation or the coning effect is something that you observe in standard USP2 when you have high density materials, drug substance or excipients, or when you put a large quantity of insoluble excipients. And these can range from any disintegrant or any microcellulose cellulose is an insoluble excipient. So if you put too much of it, you're going to have a cone forming. And we call it cone because if you look at that picture, it actually, with the hydrodynamics being really low under the paddle, you have that, and you have circulating fluxes of water. You're bringing all the insoluble together, and you make that nice looking cone. So it's really due to the dead zone, which is illustrated here with that orange space under the paddle in USP2, where the particles may enter, and if they are too big or if they are too dense, they will not escape. They will just fall and remain at the bottom of the USP2 vessel. So there are some solutions. You may want to move from a classical USP2 to an apex vessel. It's now applicable in most pharmacopoeia region, and you may solve the issue, but you have here the picture extracted from this paper B here, where you still have coning on top of the apex. So it could solve the issue, but not 100% of the time. So that you can still have very dense and very sticky drugs or excipients, which may still want to be sitting on top of your apex. So that could be an issue. But in the example I'm going to give you, I'm using the USP2 classical vessel and a drug that was dissolved at different agitation. So this is an example of a weak salt of a weak base There's 10 milligram unit solid per dosage form. They've put a lot of MCC per unit, 150 milligrams, so and they're dissolving 4 units per vessel, so 40 milligram total dose, and of course 4 times this amount of MCC, so quite a lot of MCC. The P-PSD that was fitted is this one, and I'm just putting it out there. I'll explain you how I came about that P-PSD, and it's actually going to explain all the dissolution in all those media at different agitation rate. So here you've got a summary of the impact of agitation. So if you dissolve at different, here it was different pH, different agitation, you can see there are some increasing. So at pH 1.2 with agitation from 50 to 75 RPM, you gradually dissolve more and more drug, and that's well captured by the model using infinity spin here, for example, or just the HD model. So you've got more agitation, you can dissolve more and more drug. If you run it at pH 3, where the solubility is much less, you have a much bigger jump with the infinity spin. You can see that much more drug has sedimented. And in FASIF and FESIF, you have that effect as well. So you have initial dissolution, sedimentation, and when you start the infinity spin, you can put everything again in solution. So here again, a single batch P-PSD can explain all the differences. Of course, in the model with the coning, you need to add your excipient information, so understand how much insoluble excipients you have, what is the size of the insoluble excipient, what are the swelling of that insoluble excipient, because that can change the density. So it's important to add a bit more information. You need a bit more information, you need formulation information to be able to do this modeling. But interestingly, it's used not per se to, I wouldn't recommend using it per se to catch how to derive a P-PSD for input, but it's actually helping you understand what is the agitation, what are the hydrodynamics which will be fine to run a classical model. For example, here I'm comparing the P-PSD with the coning model, the HDC model, and the classical model, which only in this case looks at the pH effect. So you can see that the at 75 RPM, the same P-PSD can explain both. So which is interesting. You see the errors are relatively similar. Of course, it's slightly worse because you're not capturing the sedimentation itself. So you have sometimes slightly higher errors at corresponding experiments, but sometimes it's less. For example, here at 75 RPM, it's actually less than this one, just by a little bit. And here it's less as well. So overall, it's the same ballpark prediction errors with the classic model when you run at 75 RPM than when you run with whether you fit it with the classic model or the HDC model. So the conclusion from this analysis is that you can get rid of coning by turning at 75 RPM, and that is a good justification for the QC method, because you want in the future to remove that coning effect, which is just an artifact of the USP2. In the stomach, in human and animals, we don't have a paddle, we don't have a dead zone, and as soon as the stomach empties, the disintegrated particles will spread along the GI tract. So there's very little impact of coning in vivo. It's never been shown. I think it's only been shown in the stomach. If you have a very dense particle, you can empty a bit later, but in the intestine, it's not shown. So if you have, let's say, if you understand your gastric residence, then the in vivo absorption, in vivo dissolution will be fine if it's predicted to happen, to be happening in the intestine. They will be spreading. So here again, using both model helps you justify your agitation, because 75 RPM is not recommended by most pharmacopoeias, so you have to provide a justification, and that's a good one, just to show you that neglecting hydrodynamics can be achieved when you have 75, and if you don't have 75, you would have coning. So the flip side of this learning is that you should, for this formulation, you should not use 50 RPM data to fit your Z factor or your P-PSD, because in this case you're artificially slowing things down. If you remember what I've shown you here, 50 RPM, if you hadn't done infinity spin, for example, you would be really slow. and that wouldn't be good, because you would predict a much slower dissolution than you have in vivo because of that coning. So that's a bias you have to be careful about. And usually a visual inspection is enough to know that you've got coning and you've got something to do about it. Right, let's finish with some take-home messages. I'm not going to spend time on this, but just to let you know that we can provide a decision tree to help scientists navigate dissolution data, understand what are the rate limiting factors, which model is best suited in which condition. I don't want to comment it today. It will be published in the literature soon as the proceedings of a PBBM workshop that happened in Washington this year. So you will have access to it, and if you have the slides, you can have access to it a little bit earlier. And associated with this decision tree, you have checklists on dissolution data evaluation, or the input parameters you need to collect to be able to do fitting of your mechanistic fitting of your dissolution. So they are always good questions to ask yourselves, and they're always good things to collect. So I would strongly recommend that you do this prior to doing any dissolution modeling and prior to introducing dissolution in your PBBM, because these are good questions. Right, I'll finish with some take-home messages. So you need to collect input data. You cannot just look at the dissolution and plug it, because if you do this, you are going to make big errors. Looking at the coning example I've just given you, it's a big error. Looking at, taking the wrong pH, assuming that it is valid across the physiological GI tract, where you will have changes of pH and biosalt composition, is completely wrong. So you cannot plug directly dissolution unless you have let's say in vivo dissolution, which is controlled by the formulation but not by the drug characteristic, and there's no solubility limitation. But in most cases, you have to have a mechanistic approach, a mechanistic modeling of your dissolution to be able to predict, for example, with and without PPI, as it was the case for acalabrutinib. The other recommendation, other take-home messages, is that ideally, once you have your final formulation, you should test, at least on one batch, multiple conditions. You need to be able to verify your assumptions. You need to be able to verify the mechanism of release, the impact of pH, the impact of surfactant, the impact of vegetation. It's really key. It's crucial. If you don't do this, you may overlook issues, as I said, around coning, around lack of prediction with surfactant, lack of pH prediction, the wrong solubility as an input. So that will really be key for you to drive your understanding and convince regulators that you've got a good model, because ultimately in vivo these are changing. If you ever see dissolution that doesn't present when you have sink, this should ring a bell, a huge bell, a massive bell, saying, oh gosh, there is something happening. And you have to investigate what went wrong. Is that if you have a plateau which is not at 100%, this could hide precipitation, it could hide degradation, it could hide polymorphic transition, it could hide many things. So or even impurities, polymorphic impurities in your product. So you need to investigate that. Do not use it unless you're sure that you've put an excess of drug and you've measured your solubility, you're sure about the solubility in the medium, and you've put too much drug, you're not in sink condition. In this case, it's fine. In all the other cases, it's not fine. So you need to investigate it. As I said, mechanistic model are preferred, and this is particularly true for low solubility drugs. You need to, and why do we need a mechanistic model in this case? Because you want to have only one batch input and then predict with your PBBM. You want to predict the impact of pH. You want to predict the impact of food, of transit. You want to predict from adults to pediatric who will display different volumes, different pH, different transit times, so all of these in vivo dissolution will be predictable if you have a mechanistic model. If you have a viable function, forget it. You're not going to be predicting pediatric dissolution with a viable function. So you need a mechanistic model. And the advantage of that model is that even in a single population, if you run a virtual bee study, you can do within subject variability, which is meaningful, not just based on random variation of your dissolution, but based on your GI physiology. For example, if you have a pH shift between one period and the other period, this will impact dissolution for a week base, for example, and that will be make the within subject variability and between subject variability much more reliable, much more sound in terms of impact on the dissolution in vivo. You have to understand your mechanism of release. So if you have an eroding tablet, if you have a fully disintegrating tablet, if you have issues with disintegration or capsule opening, you may want to correct your data. You may want to remove some time in your measured time to remove those mechanisms before you fit those models, because those models where you're looking at Z factor and P-PSD, they start at time 0. The dissolution starts at time 0, and so if you have time which is spent by the drug to swell and disintegrate, you should account for it in a way, in another way. So in GastroPlus, for example, you could use a CRU function with a Weibull function to handle the in vivo disintegration, and then let the P-PSD or the Z factor calculate in vivo dissolution after the release. Okay, so that mechanism of release has to be viewed and understood separately and handled appropriately. Finally, you need to have a quantification of your model prediction performance in vitro using the multiple conditions. So you verify your model, you show to regulators that you can predict within the pH physiological range with biosalt concentration, with synthetic surfactant, if you have them in your QC method, and natural surfactant. So it's always good to have, if you have SDS, for example, it's always good to have FASIF or PASIF, just to show that you can move from one to the other, because that the SDS may wet the API in a different way than FASIF would do, so that could become an issue because the surface will not stay constant as a function of the medium composition. So that could be an issue you encounter, and you need to verify you're not having it. And ultimately, this combination of data that you generate and understanding and knowledge that you generate on your dissolution is not wasted time, because you can understand your product performance that regulators will be expecting in future PBBM submissions, to understand the rationale for picking one method over the other. That's all from me. Thank you very much for your attention, and I'm happy to take some questions now. Hope I'm good with time. Yep.
Yeah. Thank you so much, Xavier, for the wonderful presentation on mechanistic integration of dissolution data using PPSD approach. Thank you very much for the detailed explanation. We got a lot of questions. The first question is, will acidifying excipient behave similarly to salt form in terms of surface pH and the percentage dissolved?
So it's a very good question. I would say yes and no. So as in the BMS example I was showing you, the HCl salt was creating that spring. So the salt would still be present, and in vivo in the stomach we have lots of chloride ion as well in the stomach and in the intestine. So the salt would still be playing a role to control the in vivo dissolution, but the acid excipient will create this local environment which is acidic. So it will help the salt absorb some of the, let's say, bicarbonate that is secreted in the duodenum. So help buffer this, so help prevent that precipitation that we see in vitro. But it would not necessarily act as a salt. What can happen, and I've seen it happen in vitro, is that if you add, for example, citric acid on a weak base, you may supersaturate and then precipitate to the citrate, which has a higher solubility than the free base. So your terminal solubility after precipitation may be actually changed because you are creating a salt in situ in your dissolution. So that's something I have not shown, I think I've shown it in previous webinars, but you can actually have a bell shape. You dissolve with the excipient, the acid excipient, so you can supersaturate compared to the free base. But then you gently precipitate to the salt solubility, which you've now formed in your medium. So you've created a citrate salt of the free base instead of going back to the free base. So that can change how you handle it. And in vivo, I'm not aware of any experiment that would identify that, because precipitation is really tricky. You could have amorphous forms, or you could precipitate to a new salt. So the answer is no. It's not exactly the same, but it will influence the microenvironment, and any excipient will influence the microenvironment, and you may have transition happening at the solid state. For example, with max T-rate, it's been described. You can form salts as well. So that's something that you have to consider, because that could also impact the stability of your drug product as a solid form.
Yeah, thank you, Xavier. There is another interesting question about surface pH. What is the best method to measure the surface pH of a tablet dosage form? Is it slurry pH method good enough to anticipate microenvironmental pH, or only dissolution can be reflective?
So you need both. I think the slurry pH is utilized by many authors from the 1980s, I would say, to predict the surface pH, and it's been verified with theoretical models. So that's a good method, the slurry pH. And of course, you can do it on the pure API, but you can also do it with if you suspect that you have excipients which may act on the surface pH, you can crush your formulation or use the blend before tableting, for example, to measure that surface pH. I would recommend you do that. And then also measure the solubility in the same experiment, because you can sample the supernatant, you can centrifuge sample the supernatant if you do it at 37 degrees, and then have access to the solubility as well. So I would do both.
Yeah, thank you, Xavier. Then there is another question related to type of formulation. How can we use P-PSD to model a bilayer formulation? A part of the formulation is IR, and then other formulation is XR.
Yeah, it's a good point. So in this case, if you know that the XR formulation is not sensitive to let's say solubility, dose, and volume in your GI tract, so you need a bit of sensitivity analysis that you do in GastroPlus first. You could have a mixed multiple dose where you have an IR form and an MR form in GastroPlus, and the MR could be driven by the viable function, the IR could be mechanistic, so you could have a P-PSD or a Z factor on top of your MR form and model both. Now, if it's the same drug, and what I've just said for the MR part applies, you could use a viable straight away. So, but you need to verify that. So you can do a two-phase viable, so fit the first part and the second part. And I've done this for Zolpidem MR. It works really nicely because ultimately the in vivo dissolution is very close to what you can measure with the QC method. And this, whether you do it in 900 ml or 20 ml of fluid in your GI tract is the same. But if that is not the case, if you have a MR form of BCS class 2 drug, then you could probably do a mixed multiple dose with IR and CRU. I would do that, yeah, if it's a BCS class 2. So you'd have the mechanistic model for dissolution after the release. So yeah, that would combine the two approaches.
Yeah, thank you. This question is related to DDD+. In DDD+, can we estimate the surface pH of the API with acidifying agent in the formulation?
I've done it with the API. I've shown you with acarbon. It works really nicely. It can be done, I think, for all excipients. If you have informed the PKAs, and if you've no, sorry. I think we don't have acidifiers. I mean, they're not working. I would have to come back to you on that one. I'll ask Jim. who's the expert, and I'll come back to you on that one. I know it works really nicely with the API, and it takes into account the buffer composition very well, but I'll ask with the excipients. I think we cannot, but I will confirm this offline. I'll use the GastroPlus user group to confirm, or ask Jim to comment on that.
Sure. Yeah. Thank you. There is another interesting question related to amorphous solids questions. Have you used P-PSD for immediate release tablets of amorphous solids questions? Do you think it would work well, or do you see any pitfalls, for example, from polymer gelling at different pH values?
Yes, it's a good question, and the answer is yes, I have. Unfortunately, I cannot publish on it because it's an AstraZeneca compound, and I don't have the right to tell you more about it. The only thing I can tell you is that we tried an IVIVC with a PBPK and PBBM, and it worked both with the viable function and the P-PSD approach. That's the only thing I can tell you, I'm afraid. But it was an amorphous suspension, amorphous tablet.
Sure. There is another interesting question related to GastroPlus part. So, is there a plan to implement P-PSD calculation directly in GastroPlus?
So you have it with DDD+. I think the thing that is missing, as I said and presented, is the fact that we would like to have a bimodal, at least bimodal distribution in DDD+, so we can handle more complex dissolution with at least 2 modes. So that is missing, but we can think about integrating it. But DDD+ will do a good job. And for the cases where you have sedimentation, you can use the Excel tool, which we can make available. But at the moment, we are looking at improving DDD+, and potentially in the future, we can integrate the calculation of surface pH or the impact of salts. I think there are a few improvements in GastroPlus that you will probably see after we launch GPX. But again, we can discuss this as we launch, after we launch GPX. But that's, we're looking at this. We're conscious of those limitations at the moment. But DDD+, as I've shown on the acalabrutinib example, is doing a good job. When you have first order release, you can really nicely fit the data. So I would recommend you use that tool. And then we can think about what's missing and what we can do for the future.
Yeah. There is another question, which is a combination of a compliment as well as a question. So, hi Xavier, nice presentation and mustache. How important do you think it is to consider bicarbonate buffer over the phosphate buffer?
It's very important, especially if you have a weak base or salts on a weak base. Yes, so yes, if you have an acid-base reaction at pH 6, it's important. For acalabrutinib, it was not, because the strongest pK is 5.77. So as soon as you move from the stomach to the intestine, there is no acid-base reaction. But if you have a stronger base, pK of 7, 8, 9, you need to measure your dissolution at one point, or predict your surface pH with bicarbonate buffers, because these are the physiological buffers, and they don't react the same way as phosphate. This has been published by very good people. Again, if you're interested, I can send you through references, but I can think about Creek publications. There's other groups. I think Christian Wagner as well published on that. And there's I would be putting a list in the GastroPlus user group. I don't want to miss anyone here, but there's very nice papers you can cross-refer, and yes, in vitro you would have to do this. I think in GastroPlus, what you can do in the meantime, because we don't have buffers, physiological buffers in the GI tract, we have them in DDD+, so you could use these buffers in DDD+. But in gastro, what you could do at this point is to measure the surface pH with those buffers or measure the dissolution in those buffers. I know it's hard to do because they are reactive, and then adjust the pH or to match the dissolution, the surface pH to match the solubility in these media, and then adapt either the pH or the surface solubility versus pH profile in GastroPlus, so you can capture that in Gastro. And again, this is a gap that we are aware of, and I think after GPX we can start prioritizing these gaps and addressing them.
Yeah, thank you, Xavier. That was the last question we had from the audience. Again, from the GastroPlus user group, I would like to thank you very much for the wonderful presentation and for answering all the questions very patiently. Thank you for sharing your knowledge, and I would like to hand over the virtual stage to Natalie for closing remarks.
So,
thank you, Sivacharan, for the moderation.
Thank you.
Yeah, and I wanted to thank as well Xavier and Sivacharan. So thank you very much. It was really a great webinar. And as you know, it has been recorded and it will be available on Simulation Plus website and also on YouTube. So you will get informed when the webinar will be available. I think it should be within 24 hours, something like that. Xavier, we're also looking forward for you to answer the question that was the one question that you could not answer, but the questions were all quite, good questions.
Yeah, I'll send a few references, and I'll ask Jim to comment on the impact of XCPs.
Yes, and if you could do that on the GastroPlus user group linked inside, that would be fantastic.
We'll do that.
With that, we are coming to the end of our webinar today. Thank you very much again.
Thank you. Bye, everyone.
Thank you. Bye-bye.
Bye.